Hey everyone, thanks for joining our webinar. My name is Chris and I'm a therapist specializing in evidence-based treatment of eating disorders. This webinar today is based on a series facilitated through the University of Wyoming Clinical Psychology Doctoral Program entitled Evidence-Based Treatments for Psychological Disorders. Today, we'll be discussing cognitive behavioral therapy, or CBT, for avoidant restrictive food intake disorder, or ARFID. We'll be referring to this treatment as CBT AR. Let me go ahead and share my screen and we'll get started. CBT AR is a novel form of outpatient cognitive behavioral therapy for ARFID developed by Drs. Jennifer Thomas and Kamryn Eddy at Massachusetts General Hospital, or MGH. This treatment is currently under study by Drs. Thomas and Eddy's team at MGH. This means that this treatment is still experimental and not officially evidence-based. However, there is evidence from an open trial with no control group in children and adolescents that is under revision. Another trial with adults is currently underway, and Drs. Thomas and Eddy's teams are currently designing controlled studies. The materials in the following presentation are being utilized with their permission, and materials have been adapted from the CBT AR Patient and Family Workbook. Let's begin by discussing what ARFID is. ARFID was introduced as a new eating disorder diagnosis in 2013. This disorder is characterized by avoidant or restrictive eating resulting in significant weight loss or failure to achieve expected weight gain, nutritional deficiency, dependence on enteral feeding or oral nutritional supplements, and/or interference with psychosocial functioning. ARFID is different from other eating disorders because individuals typically are not concerned with the way their body looks or how much they weigh. Instead, individuals with ARFID might have the following concerns. Some people with ARFID find that novel foods have strange or intense tastes, textures, or smells, and they feel safer eating foods that they know well. This is called the sensory sensitivity profile. Other people have had scary experiences with food, like throwing up, choking, or allergic reactions, so they may avoid the foods that make them sick or stop eating altogether. This is referred to as the fear of aversive consequences profile. Finally, other individuals may not feel hungry very often or think that eating is a chore or get full very quickly. So what questions can I answer about the three ARFID profiles?
Well, my daughter is very fussy and prefers food with a particular texture, but she's also not interested in eating and considers it a chore. Is it possible that my child would fit the description for more than one of these profiles?
No, that's a really good question. Yes, Drs. Thomas and Eddy's neurobiological model of ARFID conceptualizes the three core presentations as occurring along a continuum of severity, and therefore they're not mutually exclusive. Now, it's entirely possible what your child may present with one or two or all three of these profiles. What other questions do you have?
So how is ARFID different than just picky eating?
Yeah, and that question actually brings us to our next slide. So no, ARFID isn't just picky eating. In most cases, picky eating does not interfere with a child's weight status, growth, or daily functioning, but ARFID does. It's a psychiatric disorder with underlying biological traits and a highly resistant to change pattern of food avoidance. Typically, picky eating does not require treatment. It might seem challenging to disentangle whether or not your child has ARFID. Luckily, an easy screening tool that you can use at home might help to determine if you should seek evaluation or treatment from a trained medical provider. The 9-item ARFID screen is a brief instrument that may help measure your child's ARFID-associated behaviors. Because it was developed as a screening tool, it is as brief as possible. It should be noted that if it seems that your child might have ARFID after administering this tool, this does not confirm an ARFID diagnosis. Additional information will need to be collected by a trained clinician in order to confer a diagnosis of ARFID. So does anyone have any questions?
If based on these questions, it does seem though that my child has ARFID, how could I go about finding a provider in my area?
Yeah, so that's another great question. Let's walk through that now. There is a larger number of eating disorder treatment centers across the United States. We recommend using this tool by the National Eating Disorders Association, which will give you some options based on your location. We recommend looking online at each of these treatment centers' websites to see if they specifically treat ARFID. If they do, it is likely that they will not be using CBT AR since it is still under investigation. Regardless, you can reach out to them to ask about what their treatment consists of and determine if it would be a good fit for your child. Now, let's move on to talking about what CBT AR actually looks like. The main goals of treatment are that your child achieves or maintains a healthy weight, corrects any nutritional deficiencies, eats foods from each of the 5 primary food groups, and feels more comfortable eating. Many people have misconceptions about what treatment can look like, so I want to take the opportunity to clarify that treatment is not trying to change your child's personality, making him or her eat very unusual foods, or force feeding your child. So can I answer a question for anyone?
Yeah, so what should I expect from this treatment? Like, what's the time commitment? What's expected for me? Do I have to attend sessions with my child?
Yeah. Because this is an outpatient treatment, it is appropriate for individuals who are medically stable, currently accepting at least some food by mouth and not receiving tube feeding. If it does not seem as though outpatient treatment would be appropriate for your child, it might be worth considering a higher level of care, like a residential or an inpatient program. Finally, for patients under 16 years old who have significant amount of weight to gain, there is family-supported version. And for patients 16 or older without significant weight to gain, there is an individual version. In terms of what's expected of you and your child is expected to attend sessions weekly. Depending on your child's age and treatment goals, you may also need to attend. You can also expect to be doing some work in between sessions with your child, such as keeping food logs to track your child's progress and trying and practicing new foods at home. Okay, so any questions?
Yeah, so what does treatment actually look like and entail?
So there are 4 stages of CBT AR. During the first stage, you and your child will learn about ARFID and make early changes. You'll continue these changes and set big goals during the second stage. And then the third phase concerned with facing fears. And finally, during phase 4, you'll work on preventing relapse. Let's break these stages down a bit. Phase 1 typically lasts 2 to 4 sessions. Here, you and your child will learn more about ARFID, start monitoring your child's food intake, establishing a regular pattern of eating, which consists of eating 3 meals and 2 to 3 snacks per day, increasing the volume of your underweight child's preferred food, or if your child is at a normal weight, increasing the variety of the foods that they eat. And finally, your provider will determine which mechanisms or profiles best characterize your child to decide where to begin. A common element of all 3 modules, that is, whether your child is characterized by sensory sensitivity, fear of aversive consequences, or lack of interest, or any combination of the 3, is exposure therapy. Typically, when people think of exposure therapy, they may think about someone with a fear of spiders learning to face their fear. This is similar concept being applied here. Exposure therapy involves exposing a patient to the source of his or her anxiety to help them overcome their anxiety or distress. When people have certain anxieties, such as food, they may avoid food. Avoiding our anxieties typically produces increased anxiety. For example, let's consider a case of a child with sensory sensitivity who is afraid to eat all berries and citrus because she does not like the texture or juiciness of them. Her anxiety might increase when thinking about trying berries and citrus, and it may decrease when she decides not to. The next time she thinks about trying berries, her anxiety will increase even more and decrease more when she decides not to. This creates a cyclical pattern, and the more she avoids, the more anxious and scared she will become when she tries berries or citrus in the future. By exposing her to berries, her anxiety would surely spike at first, but will ultimately decrease as she keeps practicing. This is a fundamental component of CBT AR. During stage 2, which spans the length of 2 sessions, you and your child will learn about nutritional deficiencies, continue increasing your child's volume and variety of foods, review your child's food intake through completion of self-monitoring logs, select foods to learn about in the next phase. Stage 3 lasts between 14 and 22 sessions, and here the primary intervention or heart of treatment will depend on your child's profile. Your child's therapist will select the module or modules that are most appropriate for your child's ARFID maintaining mechanism based on the 3 profiles. If your child has more than one maintaining mechanism, your therapist will start with a module addressing your child's primary or most impairing mechanism. For sensory sensitivity, your therapist will invite you and your child to bring in 5 novel foods to each session. Your child will be asked to non-judgmentally describe each food's appearance, feel, smell, taste, and texture, and select foods to practice tasting throughout the week to help your child get used to that food. Then, you would work on incorporating larger portions of novel foods into your child's diet. For the fear profile module, your child would create a fear and avoidance hierarchy of foods and eating-related situations. Sessions would consist of exposures to these foods and situations, and your therapist would ask you to repeat these exposures for homework. Finally, for the lack of interest profile, this would consist of a series of different exposures that might relate to physiological symptoms associated with this profile. For example, your child might push their belly out, gulp water, or spin in a chair to help him or her habituate to sensations associated with eating and fullness. This module would also help your child remember what he or she enjoys about preferred foods by describing their sensory properties. Finally, during the 4th and last stage, which typically lasts 2 sessions, your therapist and child would evaluate whether their treatment goals have been met, identify strategies to keep working on food at home, and develop a plan for maintaining weight and continue learning about novel foods. So that's it for the 4 stages. What questions can I answer?
I don't have any questions, but I just wanted to let you know that I found this webinar very useful. Since ARFID is such a new diagnosis, I felt very alone having my child struggle through this, and it's nice to see that I'm not alone and I actually have many resources.
Yeah, so thank you for those kind words. You're definitely not alone, and we hope that this presentation helped you feel more knowledgeable about ARFID itself, as well as the resources you can find to treat it. Prior to ending, I wanted to share some additional resources that the National Eating Disorders Association has. Well, thank you all for coming to the webinar. I really appreciate you taking the time to be here and learn more about ARFID and CBT AR. And I hope this answered some of your questions about what this treatment looks like. I hope you all have a wonderful rest of the day and keep staying healthy and safe.